Can everybody hear me? Perfect. Well, this is the highlight of this conference. And are we ready for this? Perfect. So, it is going to be on Twitter, this debate. It will be live. And it is going to be recorded, and anybody can access it from YouTube or from our website. So, now, this debate was supposed to be moderated by Larry King, the TV legend. Unfortunately, he is not able to come because of health reasons, which is very sad. But he sent us this video. Can you turn the sound on, please, Brandon?
Teen Summit on National and Global Cancer Disparities. I'm Larry King, and here to tell you how I had really looked so forward to being with you to moderate a debate with a terrific panel of experts on the single-payer versus multi-payer health care. What's good for America? Unfortunately, I was recently admitted to Cedars-Sinai for some medical treatment, discharged days later as an outpatient, still under observation by doctors who insist I don't travel for the foreseeable future. I'd been tweeting for a number of months asking folks to join me for this summit, so I was extremely disappointed when I had to change my plans. I was very impressed to learn the foundation is building a comprehensive cancer center in southeast Nepal, and I'd like to encourage all who are able to be generous to contribute to this worthy cause. I express again my disappointment not being able to join you today. I do hope all of you have a wonderful and fulfilling summit. Thank you. Be safe.
So, having said that, we have two outstanding physicians who are nationally well-known, and they are kind of household known for names for oncologists. Who doesn't know Dr. Axel Grothe? Dr. Axel Grothe is a giant of GI oncology, and he is nationally and internationally well-known. He originally comes from Germany, and currently he practices in Tennessee. Thank you, Dr. Axel Grothe. Dr. Gary Lyman, how many of you don't know him? Can you raise your hands? Don't know him? Oh my goodness. All right. That's the way to trick you guys. So Dr. Lyman is, again, nationally well-known. He publishes all the time in all the major media, and he's interviewed in all the national newspapers and magazines on a regular basis. So yesterday I called him. I'm like, Gary, you need to take Larry's position. And he gladly agreed. Thank you so much, Gary. So now I would have moderators explain the rules of this debate and invite the panelists. Thank you.
Very good. Thank you, Binay. And it's a pleasure to be here with this very outstanding panel to discuss one of the most important critical issues of our day. We're going to present some background material, just take a few minutes to present some material that will lay the groundwork of information on this topic.
I need a password for this computer. Is the password? 5677. 5677? No, not for Wi-Fi.
No, this one's kind of complicated. I'll do it.
Okay, thank you.
So Dr. Axel Grothe is going to present, again, some background information to lay the groundwork of the topic for this debate. before we introduce the panelists.
So thanks for being here. And, for me as someone who trained in Germany, spent the first 40 years in a German healthcare system, then in 2003 came to Mayo Clinic, and thinking that Mayo Clinic in Rochester, Minnesota really represents what American medicine stands for. Now working in Memphis, Tennessee, in hotspot of health disparities, this is a very unique perspective that I'd like to contribute to our debate, and I'm really excited about the questions and answer session that we'll have. So I want to just highlight, give a little bit of an introduction into what we're talking about here, and just to make sure that people understand how unique America is in a lot of different ways. For instance, do you know what the United States, Liberia, and Myanmar have in common? It's not a quiz, of course, we're not questioning you later, but the only countries without a metric system. This is where we are right now. I don't know whether you can see that. Yeah, so these are the countries without a metric system. But for healthcare disparities and issues, perhaps more importantly, these are the countries without mandatory paid maternity leave. There's only 4 countries in the world, which is Lesotho, Swaziland, Papua New Guinea, and the United States. Just to highlight where we are in terms of healthcare expenses and how the United States is an outlier in terms of the percentage of GDP that we spend on healthcare, we spend about $1 trillion more than other countries, which is about $3,000 more per year in terms of GDP. And in 2017, most recent data, I didn't have a graph for that, was 17.8% of the GDP, and healthcare dollars make up $3.5 trillion a year. That's a year in 2017. So what do we get from that? Do we get better, higher life expectancy, longer life expectancy? As you can see here on this graph, not really. I mean, in terms of dollars spent, we're clearly ahead of everyone else, but our life expectancy is one of the complex metrics, of course, that we're facing in terms of what we get for our healthcare expenditures. We are not really on par even with the trajectory of other countries. Now, I do realize there are a lot of factors contributing these, facts that I just mentioned to you. But we need to unravel the multifactorial nature of these issues, and perhaps, and this kind of leads into our debate, how do we really want to design healthcare in the United States? Another little tidbit here in terms of the United States makes up about 4 to 5% of the world population, but spends 46% of the world drug sales are spent in the United States. The rest of the world, 96% of the world population, and 54% of the drug sales worldwide. Key facts, and some of them you already heard earlier today, I just want to put this into our discussion. In a New England Journal commentary in 2012, it was mentioned the United States at that point spent $361 billion annually in healthcare administration, which is 3 times the cost of our spending on cancer, just administering our healthcare. And you heard it earlier today, research from Fred Hutch, published in JCO 2016. Cancer patients are 2.5 times more likely to declare bankruptcy compared to healthy people. And those patients who go bankrupt based on their healthcare costs, even 80% more likely to die from their disease compared to other cancer patients. Now, I'd like to finish this with the definition of universal health care by WHO, and this doesn't mean single payer versus multiple payer. It's just kind of what the WHO really wants us to achieve as a goal for a sustainable development goal set in 2015. Universal health care means all individuals and communities receive health services that they need without suffering financial hardship. It includes a spectrum of essential quality health services, health promotion to prevention, treatment, rehabilitation, and palliative care. Universal health care. And I do believe that we likely agree that we like to see universal health care. The question is, how do we get there? And this is the topic of our debate, single payer or multi-payer healthcare system in the United States. Thank you.
Thank you, Dr. Grothe. So I'd like to briefly introduce our 3 debaters, and then we'll ask for each of them to make a introductory statement about their positions. First of all, Dr. Gary Kaplan. Dr. Kaplan has served as chairman and CEO of the Virginia Mason Health System in Seattle since 2000. He's practicing internist at Virginia Mason, received his medical degree from University of Michigan, is board certified, of course, and is recognized as one of the most influential physician executives in healthcare in the country. Please welcome Dr. Kaplan. Second is Dr. Edith Mitchell, who's come to us through some travel difficulties, but has made it here from Philadelphia. Dr. Mitchell is clinical professor of medicine and medical oncology in the Department of Medical Oncology and director of the Center to Eliminate Cancer Disparities, as well as associate director of diversity affairs at the Sidney Kimmel Cancer Center at Jefferson University. Please welcome Dr. Mitchell. And third, but certainly not last, is Dr. Otis Brawley. Dr. Brawley is currently Bloomberg Distinguished Professor in the Department of Oncology in the School of Medicine and in the Department of Epidemiology at the Bloomberg School of Public Health at Johns Hopkins University. Many of you know Dr. Brawley in his previous role as Chief Medical and Scientific Officer for the American Cancer Society and Director of the Georgia Cancer Center at Grady Memorial Hospital in Atlanta. Welcome, Dr. Otis Brawley. So we certainly have an outstanding panel of debaters and discussants, and we're just going to dive right into it and maybe start on the left-hand side, our left-hand side here with Dr. Kaplan. You've heard the introductory comments, and the issue that we'd like to start off discussing is what is going to help us solve this problem? Are we better going into a single-payer type healthcare system, or to stay and somehow improve a multi-payer healthcare system? Give us your perspective on this.
So thank you very much. Thanks for having me. I would say that this is not a simple issue. I think we know that. If it was, we would have solved it already. And so it's quite complex. And we talk about single payer, but it really can mean different things to different people. If we're talking about the legislation that's been proposed by our Representative J. Paul, right here in Seattle, and others in Congress, I think we're talking about a path forward that can bring universal coverage. We have not yet seen a market-based multi-payer system get anywhere close to universal coverage, and I think for the purposes of this discussion and the impact of disparities on our communities, on our society, on the cost of care and the health of our population, I think we have to move in a big way to universal coverage. So I would have to come down as a soft single-payer advocate. My colleagues, many colleague executives, CEOs of health systems like my own, are mostly opposed. Our specialty societies, our hospital and medical associations are opposed. But when you get under the hood and look at what is the source of the opposition, it really boils down to rates. We are already under tremendous reimbursement pressure. And so when I say soft single payer advocate, I cannot advocate for a single payer that pays everybody Medicare rates. We'll call it tremendous destabilization of our healthcare industry and our system. So I think we need what I might term an American-style single payer system if we're going to make that giant leap.
Yeah. Let me just explain the little ping that came in.
I heard that.
Which kind of indicates the end of your allotted time, because we'll try to keep a discussion going. So really appreciate that. Very great.
I'm ready to yield the floor.
Yield the floor, yes. And give your last 15 seconds to Dr. Mitchell. Edith.
So thank you very much. I think we realize that we have a healthcare problem in this country. We're spending too much money. There are too many people who have lack of access to care. And when we think about the single payer name, it's really almost synonymous with Medicare for all. And what I like to say is, Let's look at what we've gotten from Medicare. Medicare enacted in 1965, and therefore it provided access to care for many individuals over 65, but later others added end-stage renal disease, hospice care, ALS care. So therefore Medicare has been changed over the years, and why not expand Medicare to others so that more people benefit from it? And therefore, I'm in favor of a single-payer system. We've had multi-payer systems for years, and it hasn't worked. It has cost more money. Yet we have our medical societies really against it. Pharma, AMA, the ACP was halfway against it. And therefore, we've got to realize that we have too many individuals who have lack of access to care, and that lack of access to care is putting burden on hospital systems because individuals show up there, they have no coverage, but yet they're sick and they get cared for. So we need a system where we are providing care to all individuals and therefore managing the cost of health care, but also enhancing prevention.
So Dr. Brawley, you've heard a couple of solutions to this problem. How would you state your position on single versus multi-payer health care?
Well, my position is that we definitely need to have universal access. We also need a system where people can utilize that access, because in the United States, universal access doesn't necessarily mean that people will know how to use it or be able to use it. You heard the introduction. Warren Buffett actually once said, cost is what you pay, value is what you get. We in the United States pay very high costs, 18% of our gross domestic product. By the way, number 2 is Switzerland at 12%. Our healthcare costs $10,000 per man, woman, and child this past year. In Switzerland, it's about $6,300. That's the number 2 most expensive country. People live longer in those countries. Their cancer mortality rates are lower. We desperately have to do something. One thing that has not been mentioned is the health insurance business in the United States is one of the most productive businesses in the United States over the last 10 years. Only the oil industry has made more money. They're at 20% profits, but they run Medicare at a 5% profit. There are some things that we can do to make our system much, much more efficient, and we need to look at that. I actually favor universal health insurance that would be some type of Medicare system baseline that would allow people to buy into an insurance. Maybe have, in Switzerland, there's 6 private insurances, but everybody has a baseline insurance above it. I think Germany is something very similar to that, but we have to change.
So let me follow up on that and starting from the left again. When we talk about the political discussion right now, single-payer system is really divided in single-payer only, the only exclusive insurance there is, abolishing all the other insurance options, or allowing a mixed system at all. So where would you stand here? Is it one single payer and you're not allowed to have anything else, or is it kind of a mix of things? What do you think, Dr. Kaplan?
I would consider, and given my occupation, I have to be a pragmatist, that if we're going to move forward to universal coverage, we have to chart a course that's actually doable in today's environment. I think the political rhetoric is a significant barrier. I think we have mythology around tax rates that will increase dramatically with a single-payer system, and we have the anti-government posturing that basically says that government-run healthcare is bad. In fact, I was just researched this again with my finance team. Medicare is our very best payer, not by rate, but by efficiency. And so while dispelling all of that in my own mind, I think we need to chart a path forward that can include options, as Dr. Brawley has said, to potentially move up, buy up, but with a baseline safety net. Another interesting proposal might be Medicare Advantage for all, where the the health plans that do need to shrink their administrative costs and the chunk of money they take out of the healthcare dollar, but perhaps the Medicare Advantage plan, which has proven to be quite popular, could be expanded to a Medicare Advantage plan for all. Regardless, we need to not, as I mentioned earlier, not destabilize the system with a Medicare, Medicaid rate floor and ceiling that basically will take huge amounts of money out of the delivery systems, many of which, in their attempts to provide safety net care, are already running on thin or no margins.
Okay. So Dr. Mitchell, if we were to move to Medicare for all, do you see that really resolving all the disparities issues that we have apparent, and it's been discussed at this conference in terms of healthcare delivery and access in this country?
So no, I don't think it will get rid of disparities, but let's think about what we know. What we know is we have Medicare. It has been here. Medicare made the greatest changes in disparities in healthcare in this country, not our insurance plan. So if you think about Medicare 1965, one, it allowed access to care for individuals. It allowed for practicing physicians to actually practice medicine. It eliminated segregated wards on hospitals, doors that said white only and colored, and people had to go through the appropriate door that they identified with. So there have been benefits, not only that, access to care for whites as well as blacks in this country. There was an increase in hospitalization, but also outcomes. Individuals over 65, within 5 years of Medicare, were living longer. And the overall age of people over 65 has increased tremendously with Medicare, but there are some other plans. Veterans care. For many veterans, there would be no access to care without our VA system, so that's one system that is government owned and operated. Another is TRICARE. TRICARE works, and in fact, blacks and whites who are within TRICARE care, or TRICARE, have almost equal advantages. Breast cancer, equal in the groups, and overall survival equal, as well as other conditions. So we need a composite where we have all of the areas of care.
So Dr. Brawley, when we talk about implementing changes, evolution or revolution, because that's being discussed. Revolution would mean get rid of what we have and then start anew by expanding, for instance, Medicare for all. Or should we start with what we have, Affordable Care Act, and then expand from there?
I don't think we have much of a choice. We're going to have to start with the Affordable Care Act and evolve over time. We're not going to be able to tear down our entire system and start anew. It's just not, it's not going to be feasible. I do, however, think we have to move quickly. There's some charts out there. If you look at the average cost of a healthcare policy for a family in the United States, which is right now about $19,000, a private policy, and the median cost or the median income for a family in the United States. Go back to 1960 and just look at those things rise all the way up to 2015, the last year that we have data. They're both nice swooping lines, and if we just extend them out, they cross at about 2040. The median cost of a health insurance plan in the United States and the median family income cannot be the same thing. What I'm saying is the prices are not going to continue going up as they have over the last 60 years, and sometime over the next 20 years, things are going to have to change. So I would hope they would evolve relatively quickly, but I'm going to predict that they're going to collapse the economy, and then we're going to have to pick things up.
So Dr. Kaplan,
Sure.
You've heard that there are many facets to the rise in healthcare costs in this country. One that gets a lot of attention, of course, in the media and in our profession, the price of drugs. And part of that problem is that CMS, Medicare, has not been given the authority to negotiate drug prices to try to rein in some of those prices. Would a Medicare for all system solve that, or how would you address that component of our healthcare cost problem?
I think that's a significant component amongst many, and it needs to be addressed, and it should and can be addressed independently, and much sooner than practically speaking, our ability to implement a Medicare for All program. I think that, as most of us know, as part of the deal making that led to a one-vote margin to pass the Affordable Care Act, the deal was made with Big Pharma to not touch the ability of Medicare to negotiate prices. Medicare is the single biggest purchaser of drugs in this country, and they've not used their purchasing power. I think that that is what we've got, and so that simple piece of legislation should be non-controversial unless your number one lobbying support is the pharma industry. We should be able to deal with this actually within the next 2 years. In fact, the president came into office saying he supported Medicare's right to negotiate, and then he realized that who had contributed significantly to his campaign. So I think we do have to make some major steps on this. It would need to be part of a Medicare for All program, but I think that it shouldn't wait for this country to have the political will to change our overall payment system to get this problem on the path to lower costs.
I think that's an interesting point, negotiating drug prices. Sounds so reasonable. Who would buy a house with a sticker price? Even for cars, we negotiate prices. So, Dr. Mitchell, why don't you think this is, because I think the society consensus is here, it makes sense. What do we need to do to offset the $2.3 billion of pharma lobbying that comes into the Hill every 10 years?
Well, in this country, the pharma lobby is tremendous. It spends billions of dollars. And more recently, June of 2018, the pharma, the AMA, the insurance lobby all formed a coalition. And that coalition together, and they are against it. That includes the AMA. And with the cost of drugs, we need to get the cost of drugs down. It is totally inappropriate for a drug, a single drug, to cost one amount in the United States and then next door in Canada, a less price. So therefore, we must rein in the cost. We have to get the agencies that are against these principles to work with us so that we have care for all. And the important thing is care for individuals, a lower cost, and quality. So we've got to put those things together. Remember, and I'm a member of the AMA, but remember the AMA was totally against Medicare and actually hired a very important LA actor to speak against it on our TV and news media. That person later became president, and we still don't know if he had access to, or he took access to Medicare, but we've got to get the agencies that are against it working with us so that we are providing care for all at a lower cost that is reasonable and without significant increase in taxes.
Dr. Brawley, in talking about negotiating drug prices, why don't we allow import of drugs from other countries? I mean, I can tell you the drugs that I use in Germany are as effective as the drugs we use here. Canada, there is really no reason, no medical reason not to import drugs.
Well, I'm actually not at all against importation of drugs. We do have to look at quality and things. By the way, there is a market, there is a gray market for drugs in the world where some drugs are actually counterfeit, so we do have to be careful about that. I will say that drug price is not the only reason, it's not even the major reason for this problem that we have in healthcare. Hospital costs far outweigh drug prices as a problem, and I also do worry about, I'm saying drug prices are too high, but I do worry about innovation. That if we cut drug prices too much, we will decrease the amount of scientific innovation in the United States.
So I'd like to follow up on that with Dr. Kaplan. In your role in the healthcare system and running a healthcare system, as Dr. Brawley just pointed out, drug prices, as somewhat obscene as they seem to be, at least the American public, is not the only thing. It's not perhaps even the biggest part of the healthcare expenditure rise that we've seen over the last couple of decades. How would you deal with the hospital side of that, or the non-drug component of the price increase?
That's an important question, and it's something that we are working on very, very hard at Virginia Mason. I know my colleague David Abulafia knows this, but we are, well, first of all, our healthcare system, by all estimates, repeatedly, in numerous studies, is thought to have between 30 and 50% of what we spend in that $3.6 trillion industry waste. No value added. That waste comes in many, many forms: administrative waste, clinical decision-making waste, lack of appropriate evidence-based care waste, pharmaceuticals. So I think, and what we've been about in our organization for almost 2 decades now, is a relentless war on waste. If you can get your cost position to be lower by taking out non-value added variation, what we've learned using what we call our Virginia Mason production system is that, patterned after the Toyota production system, is that quality and safety can increase. Quality and safety can increase at the same time that cost is reduced. And not only that, it's better for the people doing the work, and certainly for the people experiencing the care. And so I think we as a delivery system, as hospitals, clinics, we have to own our part of the problem, and we have to be willing to challenge ourselves to change the way we practice, change what we do, become much more evidence-based, and work hard on eliminating that, what seems to be omnipresent waste.
So we just got the signal for a segment break. You know, if this was a TV show, we'd put a commercial in here, right?
You mean we're not?
We're not. No, I don't know. I mean, but I would like to open the floor just for this segment for quick, questions, from the audience, based on what you've already heard. If you have any questions to the 3 panelists. Oh, we need to. Okay, please. Can you use a microphone? Do we have a? You can use this mic. Come up here.
It won't.
It won't allow you to. Okay.
So you've all raised some great points. My question is that healthcare is not just about health anymore. It's about jobs. Apparently, it's now the number 1 sector for job driving. And so, if we give it a bigger haircut, are we not at risk of going into recession or something like that?
I actually don't believe so. You're absolutely correct that we would end up losing. It's okay for me to answer?
Yeah, please, go right ahead.
Yeah, we actually would lose some jobs in the healthcare sector, but those people, I think, are going to be quite trainable and able to go do some other things. The other important thing that has to be mentioned in taking off on your point, sir, is gluttony and waste in terms of healthcare in the United States actually kills people. I mean, there are people who die from iatrogenic interventions that are absolutely unnecessary, that's not talked about. I mean, we're at a point nowadays where the estimate is 2% of all cancers in the United States are due to diagnostic radiation or drugs. We are actually hurting people with some of our medical interventions, many of which are not evidence-based and scientifically proven. One of the ways that we can actually get a little bit more efficient is just get all the gluttony out of medicine and actually start practicing with evidence basis.
So Edith, are you concerned about the
I would like to add to that
consequences?
is that we really need to also get the administrative costs down. The administrative costs, we've got more administratives than we have nurses because the administrative costs are there. And all of the pre-certification, it's totally unnecessary and requires more and more administrators in our offices, and consequently offices are working very hard but they cannot be profitable because of all of the administrative costs. So we've got to get the administrative costs down, and we've got to get people taking care of the patients. We need the nurses and the doctors. In many situations now, with the requirements, a doctor sits at the computer and never looks at the patient, but they fill out all the forms on the computer. So we've got to get some of the requirements down to where doctors are taking care of patients, where we've got nurses working with patients instead of all of the administrative cost and requirements in medical practice.
Dr.
That's why
Kaplan, you wanna-
doctors are burning out
You want to weigh in on this,
because of
Dr.
too much
Kaplan?
work.
So I totally agree with you as a clinician, practicing clinician, and as an administrator. I think we need to eliminate the non-value-added work. We need to eliminate the waste. We need, as I say at Virginia Mason, we need all the people we need and only the people we need. I think the point made about jobs is important, and it's one of the reasons we are going to continue to see resistance to this change. One person's waste is another person's income. And so we've got to be willing to admit the fact that we have built overcapacity in our healthcare system. When we have too many beds, people need to fill them. When we hire too many administrators, these are jobs that people are going to fight to protect. But I do believe that the biggest source of administrative waste is extraneous to the delivery system. I'm biased about that, but delivery system, and comes from the regulatory burden of this chaotic non-system that we call the U.S. healthcare system. We have people who are not practicing at the top of their license, doctors not doing doctor work, nurses not doing nurse work, and on, and it's because of this dysfunctional system. So it gets us back to the original premise that we need to change the system in order to rationalize it around both quality, job satisfaction, and the cost of care.
If I can just interject, to call it a system is an affront to the word system. We have to change the culture of medicine and change both how we provide medicine and how we consume medicine. One of the things that we don't practice enough in the United States is prevention, actually getting out there and actively trying to prevent disease. We don't even have a mindset of prevention. I've spent a lot of time in Europe, and some of my colleagues here can verify this. If you have an attending physician with a medical student seeing a 60-year-old man newly diagnosed with hypertension in France, that physician might prescribe 20 milligrams of lisinopril and say, come back in 3 weeks and let's check your blood pressure. In the United States, the exact same thing would happen. If you ask the French medical student why was lisinopril prescribed, the French medical student will say it is to lower the patient's risk of cardiovascular and kidney disease. It is to prevent disease. If you ask the American medical student the same question, why was the lisinopril prescribed? He'll look at you like you're a fool and say, well, it was to treat his high blood pressure. The American medical student from the beginning is oriented toward making a diagnosis, because we bill on diagnoses, and treating. The French or German medical student is much more oriented toward how can we prevent the patient from getting sick.
So let me chime into it. I like the discussion a lot, and with the recent implementation of EPIC at Mayo Clinic, I can tell you this is not a medical documentation system, but a billing tool, of course, and we know this is what EMRs really are. They're not meant to transmit information from provider to provider, but really to make it easier to bill for reasons, etc. My question that I have to Dr. Kaplan is, should insurance companies, by definition, health insurance companies, by definition, be able to make profits? Should they not all be non-profit organizations?
That's an interesting question. I'm a big believer in not-for-profit medicine, and but what I'm increasingly seeing is that the difference between not-for-profit and for-profit becomes blurry. Both for-profit providers and not-for-profit providers, they have the same issues we have to face. I think what needs to happen, whether they're not-for-profit or for-profit, is there needs to be some cap on, so, you know, capitalism is a great way of life, but unregulated capitalism with no boundary conditions makes the rich get richer and the poor get poorer. And that's I think, one of the issues in not-for-profit healthcare, that the CEOs of United Healthcare or Cigna, Aetna are making, you know, $20 million on a bad year. That's somewhat obscene. So I think we have to take a look at what is it that these organizations are doing. I don't come down on one side or the other, really, but I do believe that not-for-profit organizations need to have a margin. We need to continue to invest as not-for-profits. We're all, I think, part of not-for-profits. And we worry about the for-profit insurance companies, but some of them are actually doing some interesting, creative things in the industry. So I think I will take a look at the whole insurance industry as a whole and say, do we need them? What value are they adding? And I think that's one of the important questions in a broad single-payer system versus more of an incremental Improve the Affordable Care Act approach.
So one of the problem areas that has been stated of this albatross we call the American healthcare system are the middle managers, the pharmacy benefit managers that seem to have a middle role, but not a critical role, other than they've imposed themselves, or they've been allowed to impose themselves between the provider and the patient, the recipient. Any views on dealing with that component?
Well, let me defend. Go ahead.
As a practicing clinician, I see this all the time, where the middleman, one, they hire people who don't even understand medicine, and they read from a pre-written line and tell you why the procedure is denied, why the diagnostic test is denied, and then you have to go on with these individuals to explain it, to get it covered. That whole area should be, get rid of the whole thing, because one, the individuals don't know what they're doing. They don't understand medicine. They probably have less than a high school education. They're reading from script, and it's not needed. We should be able to, between the physician and the insurance company, get what we need for patients. Moreover, with the insurance companies, the high cost of insurance plan is ridiculous. You have a family on four, $60,000 income, and they buy a policy that costs $10,000 and has a $7,000 deductible. So they aren't going to get any care until they pay $17,000. It's ridiculous. So we need to work with all so that we come up with a plan that takes care of patients at a reasonable cost and with quality care.
And see, I actually would be a little bit defensive of the medical insurances who have put some guardrails up and sometimes some obstacles to our malpractice and mispractice of medicine. I'm thinking about such things as, let's look at history. In the 1980s and 1990s, it was the health insurances who first stood up and said, those bone marrow transplants that you're doing in breast cancer are not scientifically based. Indeed, they fought in the courts against some of those things. Of course, that's the procedure that in 1999 was abandoned because 3 randomized clinical trials that were completed 19 years after we started doing it showed that it net killed people. Okay, just this past week I've counseled patients who are thinking about proton beam radiation therapy, which costs $80,000 as the physician's professional fee for prostate cancer, when we have a randomized study that suggests that IMRT at $18,000 is actually more effective. So I actually am a little bit defensive of the insurance companies and their obstacles. We have a lot of waste in medicine, a lot of gluttony, and a lot of it is the doctor's fault. Doctors not taking responsibility. Some of it is doctors giving patients what they want because they fear the patient will walk away and go to another doctor and get the non-evidence-based expensive treatment that actually may be net harmful. So we need to change our culture of how we provide medicine and how we consume medicine.
Very brief comment. I think, Dr. Lyman, your question was about all intermediaries of sorts, and there are many. And everybody, when you have an 18% of GDP revenues, potential revenue stream, everybody wants a piece of that pie. And so in this community, interestingly, 90+% of healthcare that employers provide in the commercial sector work with benefit plan intermediaries, so-called brokers. Now, I don't know who's in the audience. I hope there aren't any brokers here. But you know, you have to ask yourself, why have the employers been very resistant to using their purchasing power? Why have they been reluctant to move in a much greater way, faster way to pay for value? And it's because of the people that are advising them have an interest in maintaining the status quo. Yeah. The transaction-based system is making a lot of money for a lot of people. And so, again, it gets back to waste. In every dimension of this industry, what adds value ultimately for the patient and what doesn't. And I think that a lot of these intermediaries do add some value, whether they are required to be the ones to put up the guardrails to over-exuberance with some of these new technologies, or whether we need some of these intermediaries. You know, it varies. But I think we ought to be willing to challenge the status quo.
So, Dr. Brawley, can I challenge you in one thing you said? Because you kind of try to defend drug costs based on R&D and development, etc. So recently there was an article in JAMA Network Open about the return of investment for one research dollar for drugs in the United FDA-approved drugs, where we had at least 10 years of sales experience. And the return per dollar was $14.5. Can you name any other industry where, you know, $1 turns into $14.5 within 10 years? I mean, that's pretty remarkable. And in addition, I would challenge you in the way that a lot of research is not necessarily done in the United States. When you run an FDA registration trial, the FDA wants you to have 10 to 20% of American patients participate, but more and more non-American trial data are accepted. So companies are building research centers in China, in India, anywhere else in the world, but here. So any idea how to deal with that?
By the way, I'm a little worried about shipping a lot of our research overseas as well. That's another issue.
I completely agree.
I'm not willing to stand in front of the drug companies while you criticize them for high prices. My point is that they're not the only ones. And so frequently this argument becomes an argument to criticize the drug companies and not forget the hospitals, not forget the insurance companies and their 20% profits, not to forget the other entities. The device manufacturers are awful in terms of some of their costs. You know, I have what Office Depot calls a screw. My orthopedist calls it something else, such that he can charge $3,000 for it. You know, if I bought a sterilizer and went to Office Depot, it would cost me 75 cents. But I have that screw in my shoulder. They call it an anchor in orthopedics. We need to look at everybody, not just the drug companies, was my point.
And if you were a fighter jet, they'd charge you $30,000 for that screw. Dr. Mitchell, and I guess any of you can chime in on this. I know you have no political convictions whatsoever. However, we are approaching the 2020 elections season, and I think we're already deep into it. There's some 20 Democratic candidates. Fortunately, unfortunately, we have one on the other side, perhaps. But if you were to make a case to the American people about a solution to the healthcare crisis and a reason for a single-payer healthcare system, how would you express that so that the American people would understand? Because they come at this and many of them like the idea, they want to keep their insurance, but they don't understand the details. They don't understand the underlying pinnings. How would you express it if you were a candidate for election next year?
So I would express it as Medicare for all, in that individuals could opt into Medicare at a younger age, whether it's increasing taxes or individuals paying into the system, and that would cover what Medicare costs, but also having the ability and the option for private insurance, and private insurance that is feasible for care. For that individual that has a $7,000 deductible, that's not feasible care. So we need insurance plans that people can understand, they can read, and that they can pay for. So that a new system or expanding a system that's already present, it's got to be financially feasible. And let's do that with everybody working together, develop insurance plans that individuals want. Americans want insurance, and the insurance industry is there. It's not going to keel over and, give up. So we've got to make sure that there is a process where there is buy-in, but we've got to focus on good health care, quality care, and affordable care.
So Dr. Kaplan, you mentioned, let me come back to something you said earlier, soft single payer.
Yeah.
Where are you soft? And where are you?
So if I was a candidate and was running on a single payer system or Medicare for all, I would start with explaining the why and being extremely transparent about it. Yes, of course, universal coverage. Yes, of course, a step, but only a step towards healthcare equity. But also I would start to look at the fact that the industrial sector, the business sector in our country is being extremely challenged, particularly in a global economy, because of their line item healthcare costs and the rate of rise. It's actually costing jobs outside of the healthcare industry from those companies that need to pay for it. I think we need to talk about all of those things in a very transparent fashion. When I talk about soft Medicare for all, I'm talking about reimbursement rates that are actually sustainable. Now, some have said that if you take Medicare plus 20% and made that the standard rate, that everybody would continue to have sound economics. Now, what are standard commercial rates today? They're Medicare plus 150 to 300%. If you're a consolidated entity in a market with heavy consolidation, which we have here, you can command much higher pricing. Public doesn't know that. They don't realize that when they buy a blended plan with a premium, that they may be paying one consolidated organization X plus 2 or 3 and paying another organization X. And so we need to level the playing field, we need to make it much more transparent, and we need to ensure a sound level of reimbursement and make sure the American public understand the why this makes sense for all of its citizens. And the final thing is that in the United States, and it's changing, but we have what's called a graduated income tax. The whole premise is that people pay based on their ability to pay. And I think that might be a much fairer way to fund a healthcare system. And actually, the estimates are that the total cost of care in a Medicare for All program would see total costs decrease by about 10%.
How I would address it is I think the American people need to understand that people are dying because they don't have access to care or the ability to utilize health care. You know, my old group of epidemiologists at the American Cancer Society did an estimate of how many people die because of health disparities in cancer in the United States. And the answer is of 607,000 Americans who are going to die this year, 152,000 deaths are preventable. A quarter of all cancer deaths would be preventable if we just applied not a new drug, not a new treatment, just give everybody what we currently have, prevention, diagnosis, and treatment. 150,000 lives. You know, 10 years ago, I went off on a Navy ship during the surge in Iraq. I did 9 months at sea. I was on a Marine troop carrier. And whenever we went ashore, we went under this sign that said, "We're Americans, we leave no one behind." I came back to the United States and realized we're Americans and we leave a hell of a lot of people behind.
Yeah, that's a very powerful statement. Yeah. So, Dr. Mitchell, you know, disparities are not just racially based. I mean, there's a lot of more to health disparities than just race. On the other hand, making a healthcare system available to everyone doesn't mean everyone's utilizing it. So how are you going to deal with these issues? You know, because, you know, addressing, you know, a different focus on disparities, you know, and what would be a model to make people utilize the, let's say we have a single payer system at some point, or you know, how would you encourage people to utilize the system?
So we have to look at not only racial disparities, but there are other disparities. Inner city, where there's lack of drugstores, for example, where individuals can even get their drugs. There are the rural areas where there has been the greatest decline in healthcare because practitioners are leaving, hospitals are closing, there are no medical institutions, no emergency services for 50 miles or more. So we've got to look at all of America. We've got to look at the drugs that are utilized. We just found out, even just a few years ago, although tamoxifen was available 30 years ago, why certain racial and ethnic groups do not respond to tamoxifen. So we've got to work with our innovative strategies, our research. We need to get more people into research. Not only that, physicians practicing in the local areas. It's hard for me to realize that in this country, African Americans constitute 12.9% of the population, but of all of the practicing physicians in this country, 3.9% are African Americans who are likely to go back to their communities to work. So therefore, we've got to improve our medical education. We've got to get more people into medical education who are likely to go back to their communities. So the whole issue of disparities in this country, it's more than just one disease process. It's everything, including the social determinants of health.
I was just going to comment on social determinants. You know, as we know, what we can do in healthcare is maybe influence 10, 15% of the real, you know, the individual health. And so I think we have to look at disparities in education. We have to look at disparities across a community. It's got to be much more widespread than just healthcare, which is critically important. And as we know, just treating everybody the same is not really dealing with inequity in our society. We have to bring up those that are behind, and that may take affirmative action type approaches to actually make something happen for those who are suffering in need.
No, I wholeheartedly agree with you. I've frequently said that the solution to many of America's health problems is the fixed third grade. You know, third grade is when a lot of these things, a lot of these bad habits that we develop, be they eating terrible things, not exercising, also, my calculation of 152,000 deaths that would not occur if the disparities went away, how we actually did that was we took the realization that college-educated Americans have a much lower risk of death than non-college educated Americans. 32% of Americans are college educated. And we simply said, how many people would die if all Americans had the death rate of college-educated Americans? Now, the American Cancer Society normally calculates how many people will die with the death rate in the United States. We use the death rate for college-educated Americans, and we got the 455,000 figure instead of the 607,000 figure we normally have. So that really is the effect of giving the advantages of a college-educated American to all Americans. And that, again, is prevention of disease. College-educated eat more vegetables, exercise more, and are less likely to be obese. All the screening and diagnostics, as well as treatment. College-educated are more able to use health care that they have access to compared to non-college educated who might even have insurance and access.
So we are point for another commercial break, so we'll open it up to questions. Please.
Provide from the University of Toronto, so full disclosure, I'm Canadian.
Turn off the microphone.
Rand Corporation did
Can you use a microphone? Because we're
Use a microphone. Come, please, come here.
yeah, for the people watching on the net.
Rand Corporation did a study some years ago that said if you guaranteed everything that works in medicine, 51% efficacy or 50% efficacy, and guaranteed it from cradle to death, what would that cost as a percent of GDP? It's 12%.
Yeah.
So the issue, and I agree with you very much, Otis, that the issue is about waste and allocation, but it needs, quite frankly, a big cultural debate on the waste that occurs in medicine. And all of the incentives we have are very much the other way. I mean, just if you Google Raymond Shinazi's story that Jeff Sachs wrote about, of how an Emory professor took NIH funding for a hepatitis C drug that cost $200 and now is, through all the incentives, is selling it for $84,000. So those incentives are what is driving this inefficiency. So I'm a bit pessimistic that Americans are really willing to stand up and say, we actually want to cover everyone, but it's going to have a trade-off.
Yeah, you hit me in a couple of places. Full disclosure, I'm on the medical advisory board to the Rand Corporation, and until December 31st, I was an Emory professor.
I think you raise a really good point. I think the American culture, which has been seized upon politically as everybody needs to pull themselves up by their bootstraps, rugged individualism, but I think we forget often about what it is that makes this country what it is, and that's the community, the sense of community. I recently wrote a paper in New England Journal Catalyst called "It's Time to End the Two-Canoe Argument." And there are a lot of people like me running around this country saying, woe is us. We got 1 foot in the fee-for-service canoe, and we got 1 foot in the pay-for-value canoe. We just don't know which way to go. And you'll hear hospital CEOs, doctors, lots of people talking about this stuff. To me, that's such a spurious argument. It's the antithesis of professionalism. It's basically saying, until you pay us differently, we're going to keep ordering unnecessary tests, doing unnecessary procedures, filling hospital beds with patients that don't need to be in the hospital. And I think it really is something that we as a profession, which I'm very proud of, American medicine, we need to seriously think about. And I think when you start to do that and really call the question on what it means to be a professional in this country, it's about doing the right thing and about putting others' needs above our own personal needs. And so the incentives have taken on a disproportionate role, but I think many of us in leadership need to step up and call that question.
But also, I'd like to add to that, when we think about America, we are a microcosm of lots of people. We all can't be college graduates. We need the farm workers. We need the day workers. We need those individuals who really take care of us by doing the remedial work that many of us wouldn't want to do, can't do, And therefore, these individuals don't have access to our great hospitals and our great medical centers. So we've got to think about all of those social determinants of health, those individuals who have day jobs, they work by the hour, and therefore they can't even get to the doctor because they don't have the money for taxi care or taxi or other fares. And if they miss work, they don't get paid. So we've got to think about health care for all of these individuals, because those are the ones who are coming to our hospitals to get admitted for disease processes that could have been prevented. So as we, as leaders and planners, we've got to think about those individuals. We can't think about just hospital cost or physician office, survivor, or getting the insurance companies down, because these individuals can't speak for themselves. They don't have the platforms to speak for themselves, but yet we see them in our offices, in our hospitals, and we've got to speak for them.
One question from the audience.
I'm a little bit more pessimistic than the senator from Canada there. Because I kind of feel that unless there's a skin in the game for for everyone who is part of the healthcare system, nothing will change. And if I think of the healthcare system, every single stakeholder, no one benefits from lowering the healthcare cost except the patient. So if I think from an administrator's standpoint, we lower the healthcare cost, they'll make less. Hospitals will make actually less money. If hospitals make less money, doctors will make less money. They'll have less bonuses at the end of the year. Physicians in private practice will make less money if we lower the healthcare cost. Insurance companies will make less money. And pharmaceutical companies will make less money. So unless there's an incentive for all of these stakeholders that lowering the healthcare cost will lead to somehow something that is beneficial to them, there's no way things will change. There's no skin in the game for any of these stakeholders in the healthcare system.
Yeah,
Thanks for these uplifting comments. You
yeah.
know?
Yeah. Who's the famous author who said it's hard to get a man to understand something when his not understanding is how he makes his living?
So our point's well taken. Our delivery system, though, our healthcare ecosystem does not exist in a vacuum. The reason that administrators or doctors or anybody in the system can make so much money is because society deems it so. Society is willing to pay a premium for our services. And we are in danger of being the goose who laid the golden egg, killing the goose who laid the golden egg. If we continue at this rate of rise, pretty soon the percent of GDP will be 20, 21, 22%. And this society, this economy can't sustain that. And so rich will get richer, poor will get poorer, and that will continue to increase rather than reduce disparities. So I think what you're describing is a function of how we get paid today. You're exactly right. But that's because how we get paid today. That's why we need to change the system. That's why we need to change the incentives structure, and why we need to get back to the roots of why we are in medicine. Sometimes that may mean that salaries, if you compare, many of you know this, if you compare the U.S. healthcare system to any other system in the world, and particularly the European systems, and you correct for all the variables, the single biggest reason we're so much more expensive is our salary structure, our prices, how much administrators, doctors, nurses, and insurance companies, and everybody else in the system makes from the charges they make. We don't order less MRIs or more MRIs than they do in Germany. We just charge more.
Go ahead.
And also, the American system teaches us to take care of the sick. Very little on prevention. And in fact, the cost to the physician, or the earnings for the physician who practice preventive medicine, is much, much lower than the cost of fixing something. So most doctors go into fields where they are fixing something, and fewer people into primary care and prevention. So we need in this country to influence individuals on preventive care so that we're preventing some of the diseases. We have the highest disease rate of other countries. So consequently, we need a greater focus on prevention, but we need to offer physicians and those interested in practicing preventive medicine a decent salary. They make the lowest salary of doctors in this country.
Well, I would agree with you on the prevention thing. We think about, even when we do prevention things, we think about it as treating. We don't think about treating, we always talk about treating hypercholesterolemia. We don't talk about prescribing that drug to lower a risk of heart disease. Now, one of the reasons why I pointed out that median family income and average cost of a health insurance plan can't come together is I think that we are going to have a collapse of our economic system, and that's when these people are going to actually start listening. As we get closer and closer to that, people are going to realize that their incomes are going to be at risk because the whole system is coming down because of financial collapse.
Yeah, so I mean, we're talking about barriers to implementation, because in some ways it's nice to see that, you know, we don't have a lot of disagreement here. I think we're more or less on the same page. Not necessarily right for the purpose of a controversial debate. But let me throw in there, you know, when we talk about the healthcare boogeyman, it's like socialized medicine, Canada, England, and all of a sudden everyone's scared and says, we can't do this, we shouldn't do this, this is un-American, like the metric system, you know. It's probably as much as if you try to get Celsius into the United States. So how do we need to communicate this? I mean, socialized medicine and healthcare for all doesn't mean, you know, the whole society is suffering. It's not communism. A lot of successful capitalist economies have universal healthcare. So how do we communicate this?
So I think there's a couple terms that we need to dispel the mythology around them, but we also probably need to stop using them. One is socialism, as that it's socialized medicine. The other is government-run healthcare. I don't think any of us are advocating, and I've spent a lot of time there, and actually they do some things very well, but I don't think anybody's advocating for a national health service, the NHS, like they have in England, where the government actually employs all of the consultants in the hospitals. Nor do I think we're advocating for a Canadian system where rates are deliberately designed and access to create queues. So that here in Washington State, periodically we're the beneficiaries of the province of British Columbia hitting their budget targets before the end of the year, and suddenly they've got a contract with us down here to send patients. So we're not talking about that. When I talk about an American-style system, I'm talking about having enough money to fully fund it. Enough money to not destabilize the system, to cover everyone, and the total cost by estimates of that system is a 10% decrease. But, you know, we can come back to this, but I just want to put out there are other systems. I don't know if anybody's here from the state of Maryland, but the state of Maryland has a global budget system, a multi-payer global budget system. And, you know, some of the providers think that they're not able to see as much money, but by most accounts, it works extremely well. And so we need to be thinking about this much more actively as a community.
Would you agree with that, Dr. Brawley?
I would. I think that we need to be talking more about, maybe the word universal health care is also bad, but my old friend John Sefrin from the American Cancer Society used to say, I'm not in favor of universal health care, I'm in favor of everybody having health care.
Like, no one wants Obamacare, but everyone likes Affordable Care Act. You know?
Yeah, well, he has already told us you can call it Obamacare because he cares and they don't.
So we do have a question that I think is very relevant to the discussion that's gone on. That's come from the audience. And we've talked about, the challenges and the political challenges of this discussion, socialized medicine, Medicare for all, and so forth. But so much of this, to really affect change, will require a mindset change in our political climate. And one of the issues that was brought up is, do you feel that we can truly implement these structural changes we're talking about in terms of healthcare delivery and access without campaign finance reform, which is, is fed by the problem that the candidates derive so much of their support from the industries we're talking about taking a hit if we reduce healthcare expenditures and structurally change the healthcare delivery system. How tightly do you see these things bound together? Can we affect these changes without changing the way candidates fund their campaigns and influence their positions?
Well, not only the financing campaigns, but the lobbyists. If you think about the amount of money that the AMA, Pharma, the American Insurance Corporation, how much they are planning and have already put into campaigns, into lobbying in Congress. So I think the lobbyists, I think we should start with the lobbyists, and let's try to get that reduced so that the money these areas are putting into lobbying goes into the bottom line, and that we can utilize that for health care and quality care. So yes, the money for campaigns, the money from lobbyists, it's just too much for what we are seeing the benefit from. And therefore, the money that was spent in trying to prevent Medicare legislation, tremendous amount of dollars, and yet Medicare has been the one area that has improved healthcare in this country, that has increased access to healthcare, and that has provided guidelines and implementation of quality of care. I mean, look at the hand washing in our hospitals. That was a Medicare legislation. Infections, preventing infections in hospitals, how we take care of patients in hospitals, and also for medical education, the money that Medicare pays for us to become certified in our specialties, all of that. So it's very important that we try to influence the lobbyists.
Let me come back to one thing that Dr. Kaplan said about communication, so avoiding certain words. Mm-hmm. And I think that's really critical because certain words are trigger. I mean, you can say government should take their hands away from our Medicare, because, we don't want government-run system. We want to keep our Medicare, So, again, how do we communicate this better? How do we communicate the benefits that you outlined? How do we make it politically sound?
You're right. We have to communicate to the population that we have a serious problem, and a serious problem so serious that we need to fix it. Now, I have already said I think it's going to require a cultural change in how we as doctors provide health care, doctors in hospitals provide health care. It's also going to require a cultural change in how consumers consume health care. When I say a cultural change, we've had two really big cultural changes in the United States over the last 50 years, and we're maybe a third. The first is how we deal with race. There was a time when there wouldn't be two blacks up on this stage, not in my lifetime, and how we deal with smoking. Those are big cultural changes. The third is I think women are really coming forth right now. There were only a quarter of my medical school class was female. If you go 10 years before that, it wasn't even 5%. And now I'll bet you most medical school classes are over 50%. Those are three cultural changes. We need to have a cultural change in how we consume health care and how we provide it.
I think it's going to take an all-hands-on-deck educational process. And I suspect you know a lot more than I do, but what did it take to really stem the tide in smoking behavior? Seatbelts. Some things that we've done in this country through massive public education, I think it can have an impact. And I think the big challenge, you articulated it, is the enormous, exorbitant amounts of money that are that are influencing our political candidates. So short of campaign finance reform, which will not happen anytime soon for the same reasons, because the lobbying industry is going to prevent you taking away our, our gravy train for our political campaigns, and the recent Supreme Court decision that said that, basically corporations are people, they can give as much as they want, unlimited donations, these are things that are conspiring against progress in the direction we need to go. So we're going to have to figure out a way to change the conversation in this country and identify political candidates that are not on the take.
We also have to look at community engagement. There's not one shoe fits all in terms of educating the public, educating our congressmen and women. We need our communities. Every community is different. Even in Philadelphia, South Philadelphia is very different from West Philadelphia and totally different from North Philadelphia. So we need to engage individuals in those communities who speak the language, who know the issues, and know how to communicate with individuals to promote whatever effort we're talking about: preventive health, prevention of smoking, discontinuation of smoking, nutrition, all of those things. If we talk about them here, but yet they are not implemented in the communities, and who's going to implement it in the communities? The community leaders. So we've got to work with everyone.
So we'd like to wrap up, but give each of you 2 minutes. You can take 15 seconds more to add anything that you don't think we've covered, or just to reinforce the messages that we've already covered in terms of the U.S. healthcare delivery system and the steps forward, where we go from here and how we're going to make a pivotal change in care delivery in this country.
So I guess I'll start by just going back to what I said at the beginning. This is, and obviously this discussion I think further demonstrated, this is a very complex challenge for us as a society. But it's a worthy challenge. We have so much at risk. The great work that all of us do for our communities and our patients is actually at risk. I think if we don't step up and help to influence the change that needs to happen, it's going to happen to us. And so even those who say, no single payer, don't change anything, we've got the best healthcare system in the world, which we do if you have complex cancer, if you have complex heart disease, but if you're a newborn or in the 9th month of pregnancy, we don't. And so we have to be willing to change the conversation and to confront the challenges we have. Cost of care, universal coverage, a fragile delivery system today, fragile for all kinds of reasons, including the burden of work as well as the amount of money that many are getting paid. Physicians not accepting new Medicare and new Medicaid. Well, why is that happening in many communities across the country? The political reluctance to get involved in the polarization, the absence of transparency, and then within our own shops, the complexity that we have, the waste that's present. We've got to be, we've got to say this is a top priority for our country. It's a huge priority for our country to be able to remain a great place to live. We've got to bring those who are not experiencing what some might call the American dream. We've got to bring their standard of living up in this country, and it's going to take modifications in our healthcare system to do that.
Dr. Mitchell.
Thank you. I think that we all must look at what we can do, and instead of talking, let's bring action. We need the action. It can start in this room. We all have access to our legislators and Congress people, so let's work with them. Let's let them hear what we want and ways to get there. Bombard them with information, bombard them with people, so that we are affecting the legislation, the insurance industry, education, all of these components. So we need to do a 360 with all of these ideas somewhere along the perimeter and make sure that we focus on each strategically so that we're getting somewhere. And what we're doing in many situations is contributing to the gluttony, the lack of health care, the lack of reform, the lack of education. So let's all look at what we can do and how we can fit ourselves around that 360 so that we are affecting healthcare in this country. This is the time, and we need to do it now. Thank you.
Dr. Brawley, you get the last word on this.
You know, about 10 years ago, I wrote a book, and I said, the system is not failing, failure is the system. Medicine has too much become a business for those of us who provide it. I think we need to change the culture of how we provide health care. I think we also need to change the culture of how people consume health care. We haven't talked about Dr. Google and how people decide that they want certain things, but we really need to get back to evidence-based medicine and an appreciation of science. Actually, I'm reminded, last time I was interviewed by Larry King on his show, Suzanne Summers was on the show with me, and we had a little discussion, and I mentioned the scientific method, and she tried to explain to me why the scientific method doesn't work. I think that's a problem in the United States. We don't appreciate science, we don't appreciate evidence, and this is all part of this cultural change that we're going to have to make. And we're going to have to make sure that people understand, number one, this is critical, our economy is going to fall down. And even, by the way, when we calculated that 150,000 cancer deaths avoidable, we went out of our way, by the way, to say over 100,000 of the 150,000 deaths avoidable are in white Americans, to make sure everybody knows everybody has a stake in this problem. Thank you.
Right. Thank you. That's all. Thank you all. Don't forget the gala dinner.